All right, let's jump right into this explainer. Today, we're focusing entirely on the mechanics of the right heart, specifically the pathology and management of pulmonary valve disease. If you've ever wondered how clinicians actually decode the complex whispers, murmurs, and clicks of the human heart to diagnose serious structural issues, well, you are in the perfect place. We're going to break down exactly what happens when the heart's built-in doorways stop functioning the way they should. Here's our roadmap for today. We'll cover pulmonary valve disease, understanding pulmonary stenosis, diagnosing and treating stenosis, pulmonary regurgitation causes, and finally, prosthetic heart valves. So getting right into sections 1 and 2, pulmonary valve disease and understanding pulmonary stenosis. Let's start with our heavy hitter, pulmonary stenosis. Fundamentally, this is a narrowing of the pulmonary valve. It actively prevents blood from flowing easily out of the right ventricle and into the lungs. Now, while it can be acquired later in life, sometimes showing up in what's known as carcinoid syndrome, we're mostly looking at a congenital defect here. This means patients are typically born with it, either as a totally isolated issue or packaged with other abnormalities like Fallot's tetralogy. When looking at the clinical literature, the disease is generally divided into 3 clear pillars: clinical features, investigations, and management. It's a highly structured, super logical way of thinking about a mechanical failure in the body, and we're going to unpack these so you can see exactly how a doctor connects the dots. The truly fascinating thing here is that this disease leaves a very precise auditory footprint. It's a clear diagnostic roadmap. Because the valve is narrow, forcing blood through it is literally like putting your thumb over a garden hose. It creates tons of turbulence, and that turbulence creates an injection systolic murmur. It's a sound that's loudest at the left upper sternum and actually radiates towards the left shoulder. If you have the patient lean forward and breathe out, you might even feel a physical vibration on their chest wall. We call that a thrill. You'll also often hear a sharp click right before the murmur. Plus, because the right ventricle is struggling so hard to push blood out, the ejection is delayed. This causes a wide splitting of the second heart sound. The heart is essentially broadcasting an acoustic map of its own problem. But what happens as the disease progresses? Well, if the valve gets extremely tight, the clinical picture intensifies dramatically. That murmur we just talked about, it transforms into something remarkably loud and harsh. Furthermore, the normal sound of the pulmonary valve snapping shut, the P2 sound, becomes completely inaudible. Physically, because the heart muscle is working overtime, you can observe an increased right ventricular heave. You can even see the backup of pressure by just looking at the patient's neck, or prominent A waves will actually appear in the jugular pulse.
Moving on to Section 3, diagnosing and treating stenosis, and confirming that clinical picture.
Once we suspect stenosis based on what we're hearing and seeing, we rely on a trifold investigation strategy. Doppler echocardiography stands out as the absolute definitive test here, but look at how these tools complement each other. An ECG might give us a clue by showing a right ventricular hypertrophy, meaning the heart muscle is getting thick from all that extra workload. A chest X-ray might show post-stenotic dilatation, which is basically a ballooning of the artery just past the tight valve. But Doppler echo is the gold standard, simply because it lets us actually see the blood flow and measure the exact pressure gradient across that valve.
Now, if that ultrasound comes back showing only a slight narrowing, the clinical approach might actually surprise you. A mild case isn't a cause for panic and, honestly, often requires zero intervention. Mild to moderate isolated cases are relatively common, and they typically just require careful observation over time rather than rushing anyone into the operating room. However, if that resting gradient pushes past 50 millimeters of mercury while the heart is pumping normally, we've got a severe case on our hands. At that point, we follow these exact management steps, which actually yield very good long-term results. Step 1 is a percutaneous pulmonary balloon valvulopathy. It's an elegant, minimally invasive procedure where a balloon is threaded into the heart and inflated to physically stretch that tight valve open. Now, if that specific technique isn't available for some reason, the next step is a surgical valvotomy to manually cut the valve open. But as you might guess, altering the body's mechanics almost always involves a trade-off. Fixing a tight valve often leaves it a little bit loose. So post-operative pulmonary regurgitation is quite common after these procedures. The good news, this resulting leakage is generally completely benign and really well tolerated by the patient. We've spent all this time talking about what happens when the door won't open. But what if the primary mechanical problem isn't a tight valve at all, but rather a valve that is just too loose to begin with?
That brings us perfectly to Section 4, pulmonary regurgitation causes, or the leaky valve.
Unlike stenosis, Regurgitation rarely happens in a vacuum. It is heavily tied to high pressure dilating the artery. Think about it like this. If the pulmonary artery experiences high pressure, so pulmonary hypertension, the vessel stretches. As it dilates, it pulls the leaflets of the valve away from each other, completely preventing them from creating a tight seal. So the blood just falls backward into the right ventricle. And just like stenosis, this backflow has a distinct acoustic signature. It's a classic, highly testable eponym that complicates mitral stenosis, though in practice, I'll be honest, it is incredibly difficult to distinguish from aortic regurgitation. It's called the Graham-Steele murmur. It presents as an early diastolic decrescendo murmur right at the left sternal edge. Hearing this tells a clinician that blood is washing back into the heart the very second the ventricle relaxes. To truly understand this regurgitation, you have to trace the pulmonary hypertension back to one of three underlying secondary causes. The leaking valve is often just a symptom of a much larger systemic pressure problem. It could be caused by disease backing up from the left side of the heart. It could be driven by primary disease of the pulmonary blood vessels themselves, or it could be a result of Eisenmenger's syndrome. Ultimately, you have to manage the underlying pressure to help the valve.
But before we sound the alarm bells about a leaky valve, remember that a tiny bit of leakage is completely normal and clinically meaningless. Modern echocardiography is incredibly sensitive, and it frequently picks up trivial regurgitation in perfectly healthy individuals. It's just a quirk of our biology, and absolutely nothing to lose sleep over.
All right, our final section. Number 5, prosthetic heart valves, the ultimate solution. So what happens when a native valve, whether it's severely stenotic or dangerously regurgitant, is simply beyond repair? Well, it gets replaced. The choice ultimately boils down to mechanical hardware versus biological tissue. A mechanical prosthesis is incredibly robust, but it generates distinct prosthetic sounds or clicks on auscultation. You can literally hear the machinery at work in the chest. A biological prosthesis, however, utilizes specially treated pig valves or human allografts. These behave much more like native tissue and operate far more quietly.
If you're going the mechanical route, these three specific designs are your standard workhorses: the ball and cage design, the tilting single disc, and the tilting bileaflet valves. They are all absolutely brilliant feats of biomedical engineering that restore proper unidirectional blood flow and save lives every single day. But because of their design, they forever change the natural acoustic rhythm of the patient's heart, leaving them with that distinct audible click.
Which really leaves us wondering what the future holds for the sounds of the heart. As we continue to refine biological tissues and entirely new forms of heart valve replacements, will we see a day when the mechanical click of an artificial valve is something you only read about in history books? It's a fascinating thought. Thank you so much for joining me on this explainer. I really hope this breakdown helped illuminate the complex mechanical world of pulmonary valve disease for you. Keep exploring, and I'll catch you on the next one.